Okay. All right, so raise your hands if you can see the PowerPoint slide. I just want to make sure everybody can see. Okay, fantastic. All right, well, thank you for joining us today to speak about an issue that seems to be becoming more and more urgent every day, energy and healthcare. At a time when our world is under siege, just trying to get my next slide. At a time when our world is under siege by a microbe that's too small to see, the need for universal health care has never been greater. We hear stories of patients who are unable to obtain diagnostic tests that they need, hospitals that are incapable of keeping up with the demand for inpatient care, and intensive care nurses and doctors who are needing to make the unfathomable decision about who should live and who should die. While these stories are new to many of us in higher income countries where we have come to assume that we can and we should always be able to access timely, appropriate, and comprehensive care, they are not so unfamiliar to those of us from lower income countries who are often finding that resources in health centers are scarce and emergency services are not necessarily assured. One part of this story rarely gets mentioned. And even though it's entirely essential for care, we fail to hear about this often enough, and that's energy. Clean, reliable electricity. As a physician myself, it never occurred to me that a lack of electricity could be a barrier to emergency services until I began working in Africa in 2008. As an obstetrician, I was studying why so many women were losing their lives each year from complications of pregnancy and complications of childbirth. In a state hospital in northern Nigeria, and that's where these pictures are here, I learned what it was like to be without electricity for more than 12 hours each day. It meant that diagnostic equipment lay dormant. It meant that blood transfusions were delayed by hours or days because there was no way to refrigerate blood. It meant that laboratory tests were not completed, x-rays could not be performed. It meant infant incubators were never turned on. It meant that equipment could not be autoclaved and instead was dunked in a series of antibacterial solutions like the buckets that you see on the slide there. It meant that operating rooms conducted surgeries by the ambient light of windows and surgeons worked without the safety of cautery or suction. And at night, it meant the labor ward looked like this. I was part of a team that was conducting a C-section one night when the lights went out. I was the only one on the team who was horrified with the realization that the only possibility of finishing the case was to use the headlamp that I had in my pocket. My experience was not unique. Tonight, hundreds of health workers around the world will be working in health centers that have sporadic electricity. The World Health Organization estimates that 72% of health centers in sub-Saharan Africa have unreliable electricity. 1 in 4 have no electricity at all. So that is why we are here. I'm going to try and set the stage for a wonderful group of panelists who have kindly offered to share their experiences working at the nexus of energy and healthcare. For those of us less familiar with the healthcare system in low and middle income countries, there are several tiers of healthcare. The lowest level are health posts or health dispensaries like you see on the left. These are the facilities that provide the most basic level of care, which could be screening patients, administering vaccines, and providing very rudimentary services. Health centers are the next level of care, and they provide the bulk of services, things like outpatient services, pediatrics, obstetrics, minor trauma, and adult medicine. And this is really where the bulk of deliveries happen throughout most countries. The World Health Organization suggests that there should be one facility providing basic emergency obstetric care for every 100,000 people in a population. And then hospitals are more the referral centers, caring for higher risk patients and complicated cases transferred from the lower centers. They perform surgeries, administer blood transfusions, and provide emergency care and the like. And one hospital, the World Health says, should be available for every 500,000 people. So as you can imagine, the amount of equipment that's needed for these health centers really vary by the tier. So at the lowest level, you may have lighting and the ability to give vaccines. There's slightly more that's available in the health centers. And then it's really hospitals that have the bulk of electricity using medical devices. Keep in mind that most of these devices were never designed to be high efficiency. So many of them can be very power consumptive in order to operate. Well, without reliable electricity, health workers end up relying on things like candles and kerosene lanterns. And what we see very frequently is health workers using cell phones that they actually hold in their mouths during deliveries so they can keep their hands free to do the work that is needed to do. Keep in mind that this also means that they're putting something that could be contaminated into their mouth and they're no longer able to communicate. Then there's generators. Those require costly and ongoing fuel, and they also are prone to breakdown, and the maintenance fees can actually render them useless in many health facilities. And finally, there's grid power, which extends to some but not all health centers. Overstretched electricity grids are prone to load shedding, meaning that health facilities can spend large periods of time without any power. Solar energy is now replacing many of these traditional sources. The systems range considerably in size, from very small little lanterns that might be used by community health workers who are actually visiting patients in their home. Then there's more targeted solar electric systems for vaccine refrigerators, and like the solar suitcase design for maternal health care that comes from my own organization. And then finally, larger systems that are designed to provide more comprehensive needs for health centers. So that would be solar panels, and in some cases, even mini grids. These systems can range in size. Some of the hospital systems, for example, put in by UNDP are as large as 40 kilowatts, but they have a complexity that requires considerable maintenance and support. So today we're going to be talking about various approaches to electrifying health centers, focusing on solutions that can scale, in particular for public health centers. We're going to be hearing from Ministry of Health experts, UN leaders, and on-the-ground practitioners about the best practices, challenges, and models for sustainability. I'm not going to go into full biographies. Those are available to any of you online, and I want to save our precious time for the speakers themselves. But we'll also be talking about COVID-19. In the midst of this pandemic, well-equipped and electrified health facilities are more important than ever. From initial screening, testing, and treatment, power is really critical to providing quick and high-quality care. So while all of us at home are wondering about infection control and PPEs, ventilators, hospital staffing, low and middle income countries have the added burden of worrying about electricity. Imagine trying to ascertain whether a COVID-19 patient is actually sick or not while you're completely in the dark. Imagine being a physician being unable to use the very machines that are designed to save lives. It's very clear that energy is an important and essential enabler of healthcare. Through our work at We Care Solar, we've witnessed the transformation that can come from reliable electricity. Health workers can properly examine patients, run diagnostic tests, conduct medical procedures and surgical procedures in order to save lives. In addition, health workers tell us they're no longer demoralized to be at work, and they no longer fear going to work at night. And by the same token, patients are much more likely to utilize health facilities that are not shrouded in darkness. As part of the UN Sustainable Development Goals, we are aiming for universal health care by 2030. To achieve this goal, every health center is going to need access to electricity. And now we'll hear how people are addressing this problem and how solar energy can provide clean, sustainable solution to this global challenge. Okay. So I'm going to ask now for Bentoe, Tenhoungue from the Liberian Ministry of Health, and Dr. Bernard Madzima from Zimbabwe Ministry of Health to unmute yourselves. Actually, I can unmute you, Bentoe.
Thank you for the presentation.
So what I'd like to ask, Bentoe, is what has your country's situation been like with regards to electricity to date? And what are some of the challenges that you've been facing?
Thank you very much for the presentation. So I don't know whether Liberia is peculiar, but I think there are other countries who share this dilemma with us. Especially since after the Civil War, the country has not been able to re-fertilize the high grade. And so to date, we are largely dependent on generators. So the high grades have been only accessible to the capital city and very few communities in the capital city. That means majority of our facilities are dependent on generator. Because of the high cost of running these generators and that has caused frequent power outage in the country, we have the situation where in the middle of procedure, like I heard you say in your presentation, in the middle of procedure, the power goes off and the potential of cross-infection is very, very high. Again, because we don't have electricity in a stable and reliable electricity in the district, the health facility, and the pregnant women and their family don't feel confident, or they don't even trust the health facility. So most of these people are staying at home and giving birth. This is fueling the maternal and newborn deaths in our country, because complications set in before they can bring the person to the facility, the worst have happened. Moreover, the country, the facilities are not able to maintain the generators. And so because of this and the mix of not being able to maintain generator, not being able to have the stable electricity, this has compounded the situation in majority of the facility. So to date, in short, majority of the facility, especially in the rural area, are dependent on generator. Because of the high cost of running the generator, most of the facility have frequent power outage. This has feared away the pregnant women, and so they are giving birth in the community, which is fueling the maternal and newborn deaths in this country. I can't hear you.
Sorry, Dr. Madzima, are you there right now? Would you be able to also comment on some of the challenges and why you're pursuing sustainable energy for Zimbabwe?
Laura, sorry, we're having some connectivity issues. I'm trying to help them connect, but it does look like we have Dr. Olaro just joined.
So Dr. Olaro, can you please unmute yourself? Dr. Olaro is from the Ministry of Health in Uganda, and we're talking about the challenges of grid and other sources of traditional electricity and why countries are pursuing sustainable electricity. So can you please comment to us about why you've been pursuing sustainable electricity in Uganda? And I'm trying to unmute you. Let's see if I can do that. So Dr. Olaro, I'm unable to unmute you. Are you able to unmute yourself? Ah, very good. Thank you.
Yes. How are you?
Very good. So you're talking to about 50 people right now. Actually, 68 people are listening to you.
Okay.
So please talk to us about why you're choosing renewable energy in Uganda to support health facilities.
Oh, yes, thank you for the question. I have just joined in, and now because of COVID, we are in a lockdown, and also there's a curfew. So, but going back to the safe energy for health, definitely you know very well that the light energy is key to service delivery, because the satisfaction And we've seen that the facilities definitely which are well lit, there is satisfaction both for the service providers and also the patients themselves. And even the willingness of the patients to come at night to a facility depends on the availability of light. So,
Dr. Olaro, why does distributed renewable energy, why is that a good solution for Uganda? Why choose that over other alternatives?
first you are aware definitely that Uganda definitely has got, in terms of the availability of the, I might not be able, because I've been stopped here by police, so I have to first answer why I'm moving at this time. Probably I will join in later.
Okay. So Bentoe, I'm going to turn back to you for a second, please. I'm going to try and unmute you. Let's hear from you, Bentoe, about why distributed renewable energy is an appropriate solution for Liberia.
So for Liberia, make the service provider themselves confident to provide the critical services that they need to provide.
Huh?
Keep going.
Are you hearing me?
Yeah, please go.
All right. And the fact that we started a little pilot with WeCare Solar to light the facilities, the majority of the facility that did not have the grid, that showed incredibly improvement in the number of women that started coming back to the facility to give birth, because you can see the face of the provider, you can see the environment in which you are giving birth, and so you are not delivering anymore in the dark. So this has helped us a lot, bringing back increasing the number of deliveries that are taking place in the health facility. Moreover, when the place is slated, as we have seen when we started this pilot, the provider is confident that she's not going to infect herself as well as not infecting her patient. She is confident because she could know how to do all the third station labor, but she could not do that. She could not do that professionally in a dark room where she assists in the birth. But now that the room is lighted, we see that the provider themselves have confidence, and at the lower facility, the number of deliveries that are going on now is high. Before, there was no electricity. When the community referred the woman and there's complication, they had to refer to the hospital. And even the referral system to have the ambulance come from a hospital that is like 9 hours away from this a clinic, and getting this woman to go back another 9 hours is 18 hours, most of those cases end up dying. But now that we started doing the solar system, we see that the facility are performing more deliveries, the referrals are fewer, and only very critical issues that they cannot take care of. But most of the referrals were due to there is no light, I don't want to take a chance. So this is one of the main reasons why we want the solar energy, which is reliable and which is giving confidence back to the provider as well as the clients.
Thank you. So Dr. Madzima, I'd like you to please speak to why in Zimbabwe you have chosen to go the route of renewable energy. Why has the Zimbabwe Ministry of Health chosen to use distributed renewable energy?
Thank you, Laura. Thank you for inviting me on this panel. So for Zimbabwe, really, it's a question of using solar because it's actually in abundance in this part of the world, and it's clean energy. So that's the first point. But then the second point is our electrical systems have not been grown in the population. So we've really seen that elevating to solar instead of the normal electricity is actually cost effective for government. Mm-hmm. It's clean, and we can actually reach out to the in the rural areas. So I'll give an example of the Weekend Solar project, which we are implementing in the clinics, the rural clinics, rural health centers. These are far places where there are no electricity. There's no electricity.
Excuse me, Dr. Madzima.
Really proven to be handy.
Dr. Madzima, I want to make an announcement. Can everybody who is not one of the panelists turn off their own video? I want to see if that's going to help us to hear our speakers, please. Dr. Madzima, what you were saying was very helpful, but not everyone could hear it. So we're just going to have them turn off their video. If you're not a speaker, please turn off your video. Thank you. Okay, Dr. Madzima, go on. I heard you saying that you were saying energy is clean, and I also heard you talk about cost effectiveness, and that's one of the reasons that you were choosing to use solar electricity. Go ahead, please.
Like energy is more cost effective compared to the normal electricity, which we have been used to, which mainly is drawn from coal or from the dams. The systems which have been set up over the past decades have not been able to reach out to especially the rural health centers. And we've had power outages because of climate change. If you look at our major supplier for electricity in Zimbabwe, is the Kariba Dam along the Zambezi River. It is now at around 30% in terms of capacity. So it has not been able to draw enough electricity to serve the whole country. So solar has come in very handy. It has come in maybe in the clinics as the first line in terms of provision of electricity, but also in the district hospitals and above, it has come in as a necessary backup. So this is where we are using it. We're using it either as a first line in terms of provision of electricity, but also as backup, because we power outages, and this is also fueled by our economic situation, where we're not able to get to pay for some of our debts, where we import electricity from countries like solar.
Thank you. So we're going to mute you for this moment because we had some challenges hearing you. We're going to turn the conversation now to actually some of the people who have been trying to showcase solar energy solutions that can really go to scale. I'm going to first ask Luke Severi from Sustainable Energy for All to speak about the way that Sustainable Energy for All and UN Foundation, your previous employer, how were they approaching programs to try and scale up solar electricity in some of the countries in Africa?
Thanks, Laura, and thanks, Wendy and the team at SCOL for organizing this. I'll try to keep this brief, and I'm trying to be as structured as possible so that we're all on the same page. So what I want to talk about very briefly is the main components of basically lessons learned from several projects that we've carried out in multiple countries, most notably Ghana, Uganda, but also in Liberia and several other countries, electrifying off-grid health facilities, public primary health facilities. So really the remote ones, the hardest to reach, but those that are really serving a large majority of of the population, especially of the off-grid population. So some of these components that we feel, that we've learned, that absolutely need to be in place, it starts with what we see as a partnership with the Ministry of Health, but also with the Ministry of Energy or a rural electrification agency, to make sure that if you want to electrify health facilities, plural, like at scale, that this is actually part of a national health strategy, but equally of a national electrification strategy, so that you're well aware of, for example, where is the grid being extended in the next 6 months, 1 year, 5 years, which areas are currently scheduled to be left in the dark as it relates to grid extension, and would thus be much more suited for distributed renewable energy solutions. Secondly, having nationally anchored partners, national organizations, local organizations with the right capacity, with the right knowledge, as well as with the right credibility to work in these remote communities is absolutely critical, because it just lends all the necessary credibility, and you can leverage all the right expertise and knowledge that is needed to make this type of intervention successful. Thirdly, looking at quality, looking at the quality of the components, looking at the quality of the installation, setting up the right types of procurement committees so that you can adhere to international as well as national minimum standards. And then, of course, also having that externally validated by a third party. The fourth component has to do with the people. So activities such as community mobilization are absolutely critical to ensure that the community is part of the process from the beginning, that you can build this up from the ground, that you create a sense of ownership in the run up to the project, but equally that you drive that health-seeking behavior once the installation is up and running, to really ensure that people actually go to the clinic, because now they know there is light, there will be staff, there will be vaccines. And then the fifth component has to do with what happens once you flip the switch. That's, of course, not where it ends. You have to take into account after sales service, O&M, which stands for operating and maintenance. There is no such thing as zero maintenance. Even these nice plug and play systems, they still come with some kind of maintenance, which is absolutely critical to build the right type of capacity at the right level, and to make sure that we don't place a burden on the nurses, on the health staff, and we shouldn't aim to make them into technicians or electricians. We need to make sure that we distribute that burden in the right way. So those are the 5 main points I would like to make for now. Thank you, Laura.
Thank you so much. I'm going to turn next to Christina Briegleb, who is the Senior Global Program Director of We Care Solar. Christina, if you could unmute yourself. And I would like you to be discussing, some of the issues and the way that you've been approaching doing countrywide program scale up of the We Care Solar suitcase program.
Thank you, Laura, and thank you everyone for joining to discuss this very relevant and important topic. I'm going to talk a bit about how We Care Solar programs have evolved over time and has allowed us to scale to the extent we are today. We initially started programs, I think, as most kind of small startup organizations do, very opportunistic. So really partner or donor-led programs, which led to, in 2015 and 2016, we really jumped to more evidence-based program design and implementation. And this resulted from 2 rounds of what we call best practices review that we did. So we review all of our internal documents, we interview our partners, we see what available scaling strategies there are to really develop these best practices. And from that, we get a set of guidelines that has really allowed us to implement well, implement efficiently. So let me share some of the kind of findings that we've learned through those best practices. One was really a fundamental principle that We Care Solar has had from the beginning, which is really the system design. We really want to make sure that we have a high quality product, that the power that we have so that the panel and the battery match the loads, so you're not overextending the system, making sure that it's a very durable product. And one thing that Luke just discussed was around maintenance. So we really designed the system to have as low maintenance as possible. We chose LED lights over light bulbs that need to be replaced, and chose a lithium battery, which lasts for 5 years, over a sealed lead acid, which lasts about 2 years. So that was one of the things that we learned. Another thing we found very important from this best practices was that we need to be very intentional about our partnerships with government, with NGOs and UN agencies, and really vet those partnerships. So we started to do series of requests for proposals. We asked partners to submit concept notes and really make sure that we're working with partners that have a very similar mission and that our goals are aligned to work towards common goals. Another thing that we found incredibly important is the quality of the installation and the quality of how the users experience the solar system. So we make sure that our installers are skilled in this area, and we spend extensive amount of times making sure that they're trained, so that simple errors that if they're not installed well will lead to problems in the future. So making sure that the systems are installed with the highest quality we can, so that the system can be used for 5, 10 years or even longer. Along with that, I think a lot of times solar or equipment is installed in facilities and there's not attention towards the users. So the design of our system is really thinking about the user in mind, but then we also spend extensive amount of time on the day of installation, making sure that the health workers know how to use the system. They have basic concepts around the system and then are very comfortable and familiar using all the accessories that come with it. Another big component that we learned about for this best practice review was around sustainability, which I know will be a big topic we will discuss about later in the forum, but really making sure that sustainability is not an afterthought. It's really part of everything from the design of the system to the design of the program and who you partner with, and making sure that you have systems in place for long-term sustainability. And then another thing we learned was really efficient program design. I think there's a tendency to make sure that all districts in the country have at least 1 or 2 of the systems, but we really learned over time to be much more efficient and resource thoughtful is making sure that we focus on a district and a region before we go to other districts or regions. So through these best practice rounds that we did in 2015, 2016, we really were building an ecosystem of support, which laid the piloting groundwork for what we are doing now, which is countrywide programs. I'll just talk a bit briefly about the Light Every Birth initiative, which is an international initiative we launched in 2017, where we work with partners, governments, NGOs, UN agencies, and the private sector to ensure every woman has access to a safe, well-lit delivery in all public facilities. Light Every Birth initiative is demonstrating that solar energy is feasible in target countries, but it's also elevating the intersection of energy and healthcare at the global level through our advocacy efforts. And we're focusing Light Every Birth on 5 target countries for the next 5 years. We launched first in Liberia, as Bentoe mentioned, in 2017, and then we added on Uganda in 2018, followed by Zimbabwe, Sierra Leone, and we will be choosing a new country for next year. And our implementation is really based on 21 best practices we defined through in-depth research that was conducted by a third-party evaluator. We found the best practices review to be an excellent process for us to understand what are the evidence that we have for really good and really thoughtful implementation. And we'll be able to share maybe after this forum those 21 best practices that we developed, but they really are the kind of guiding principles for how we're able to scale at the national level. And I think I'll leave it at that for time.
Thank you so much. Excellent. I'd like to now have Huda Jaffer unmute herself. Huda is the director of SELCO in India. And Huda, I would be really interested in both hearing about your approach and in particular some of the work that you're doing to actually conduct audits on healthcare equipment as well as the energy status of health centers, and some of your work about sort of designing things in the built environment in general.
Thank you. Thanks so much for having me, Laura. Good evening, everyone. I'm glad to be part of this topic and this panel. I think sort of one of the most critical topics to be discussed has always been, but even more so today, I think. I hope everyone's doing well and safe. And why it's so critical, I do believe access to health is the biggest impediment to poverty alleviation. I mean, just a lot of what even Madam Bentoe was talking about, just in terms of the expenditure on health, huge. The transaction cost, just doesn't allow poorer populations to build those safety nets. So it's sort of one of the most crucial topics, whether you talk about, what is actually stopping people from productivity, from income generation, it is expenditure and access to health. So that being said, electrification and energy access is definitely, I think we should add 2 words to when we say energy access. We should add reliable and adequate. I think those are 2 things which we should definitely add, because a lot of times I think, when you say that electrification or energy access might, bring good health services, that's not going to happen unless it's reliable, unless it's adequate for the health center. So I think those 2 are sort of key words to add to our narrative as well. And so Laura, and when we started powering health centers, being from the energy side, we started working on the nexus of health energy about 4-5 years back. And we realized that there's a huge gap. We're powering health centers, and for some reason, there's always over design or under design, or, it's just not going in sync with the health plan. Like the health plan maybe to, make certain centers delivery points, or to add blood or trauma level care at certain points, right? Or to look at malnutrition as a focus, or sickle cell anemia as a focus. And this needs to coincide with the plans for energy. Energy health sort of come with that joint nexus, right? And I mean, just to cite some examples, we would power health centers and people would, say it's tripping and it's not working and the delivery rooms are not working. And, they're actually ending up, drying slides with hair dryers. Like you just need a simple slide warmer, but they had hair dryers to dry slides in those. So you wouldn't capture that in a very energy driven kind of health audit, right? Because it'll be like, it's just 1 hour. It's not a big deal to a health person to use that, right? And similarly, there were a lot of instances where you're not really capturing the need to design the energy rollout program for the need of healthcare, right? So what we do is basically we merge this nexus of health and energy departments, because a lot of times I think health departments, they give the list of unelectrified centers and they tell the energy departments to power those or to, add energy to those, and vice versa also, where energy put up systems on top of it, and then there's no real training, hand-holding, maintenance, etc. And some of the topics were spoken about before. But really what we do is sort of work at this nexus, and we work on generating evidence to sort of convince both health stakeholders and practitioners, as well as government departments, on making sustainable energy or energy part of their thinking process or part of their plans to roll out health programs, right? And so some of the evidence that we generate are, cases like how energy access can improve reliability of health in terms of number of services, as well as in terms of the types of services offered. So you could actually say, okay, I'm providing a really good maternal care today, but I'm able to now provide vaccine, or I'm able to now provide, sickle cell anemia detection, right? And so how can you actually look at energy as a catalyst to add new and better health services to the last mile? And I think a lot of the comments made before were also on the generator sets and the costs of diesel expenditure for many of these health. So a lot of the data that we look at when we do evidence building through the implementation that we do is really showing how much your cost per patient has come down. I mean, another case, we work with these boat clinics in Assam in the Brahmaputra River. And these are essentially boats that are providing healthcare to island communities, right? So by powering the boats, yes, you're able to provide better services, more number of services. But what also happens is your staff retention becomes much higher. The number of days you're able to go and provide the service becomes much better. So you're actually able to show the government that investing in this decreases your cost per patient over the next 5 years by this much, over the next 10 years by this much. So I think that evidence building is really what helps both policymakers and practitioners, so that it's not about energy, it's about improving health outcomes. And I think that focus is sort of critical to be maintained. And I think maybe I'll just sort of stop a bit, because already it's I think a lot of the cases have been covered. But we look at essentially that value chain that you presented of healthcare, because if you're going to strengthen a sub-center, when you're going to refer a woman for a high-risk pregnancy, but if there's no district hospital there, or they don't have good, again, you're breaking that chain, right? So because healthcare is a lot about value chain as well. So we sort of focus on that value chain, and we look at three aspects, Laura. And since you mentioned, I'll talk a bit about each of three very quickly. One is that sort of need-based optimized system design. So we do sort of joint health energy audits, and not energy audits for health centers, but health energy audits. So you kind of get outcomes on, you don't have human resources here, or you don't have certain appliances here, right? Because you could have the right appliance and energy, but if you don't have the trained staff to run it, again, you're not going to get that healthcare out. So the joint health energy audits really help sort of bring out that health need along with the energy need that complements it, right? The second thing that we look at is efficiency of appliances. I think this is something that goes so unseen in the health sector. You have companies like GE and many other companies that are now designing for low resource setting, but efficiency was never a priority, right? Because you're designing for hospitals, you're designing for the private sector. I mean, just to cite one example, if you look at a baby warmer, right now what's being sourced by most governments is 1,000 to 1,500 watts, minimum 850 watt baby warmer, whereas what's available in the market without any compromise on quality or function is 150 watt baby warmer. That reduces your energy consumption so significantly that it breaks some of the perceptions that sustainable energy is expensive, it's too, there's too much effort to roll it out, but your system design cost actually comes down between 60 to 80% if you look at efficiency of appliances. And there are literally 15,000 healthcare appliances that have not been looked at by an energy efficiency lens, right? And the third aspect that you mentioned that we've been looking at is the green building design. I mean, most of them are now using lights, fans during the day, so natural lighting and ventilation, passive heating and cooling, ensuring that, and, in heat stroke areas, in areas of, in very colder regions, in mountainous areas, looking at both thermal comforts becomes so critical for healthcare. It's just that thermal comfort level where, and given climate change, this is sort of one of the key things that health can take back. And just the last one, look at the health center. I think this is Healthcare Without Harm that actually had put down one of their papers that the health sector is, if you looked at it as a country, it would be the 5th largest polluter on the planet. So that has something to say of the connection between what health and climate change can do from paving the path to sustainable development. Thanks, Laura.
Oh, Huda, thank you. That was absolutely excellent. So I think most of us on this call are probably convinced that there's a good argument to be made for distributed energy, but let's talk about why there are challenges, what's keeping us from really doing this everywhere. And for this, I'm going to turn to our Ministry of Health panelists. So let me see, Dr. Madzima, if you're able to unmute yourself, would you be able to speak to what's making it hard to actually do countrywide implementation of distributed solar?
So whilst government or Ministry of Health, the part of the health system strengthening, there is also the issue of improving infrastructure, which I think energy is one of the priorities in terms of infrastructure at institutions. We know that most governments not been able.
So sorry, I think it says your bandwidth is low, and I'm going to need to have Christina. Can you mute him, please? So let's turn now to Bentoe. Dr. Madzima, can you please turn off your video? Because we're having trouble hearing you, and maybe without the video we can hear. Try again, sir.
So can you hear me?
Yeah, I can't hear Dr. Madzima, so let's mute him and let's go to Bentoe, Tenhoungue from Liberia. Tell us, what are some of the challenges of being able to do these countrywide distributed renewable energy programs?
So there are numerous challenges, but key to those are two that we actually think when we work on will actually help us. One is the issue of funding. We know that every country should be able to cover the needs of the country, whether it's health or other issues. And the domestic envelope of this of Liberia is limited and cannot cover all of the sector that they cater to all the needs of the sector of this country, ranging from health, education, security, agriculture, and everything. And so funding is actually an issue. That's one, and we actually need the help that we can get from any of our partners, while we also struggle nationally to put in place things that we have to put in place. The second thing is the capacity building. During the wheelchair solar, as we were working together and installing these solar suitcases and everything, we were able to work with the national level, and we trained 2 national technicians who are also EPR technicians. We also, along the line where we were installing, or where with the county health team, were able to train at least 2 persons at each facility where the solar suitcases were installed. However, the issue of attrition is still our problem. So for instance, you went to one of the facilities, you went to Mojise, and you install the suitcase, you train 2 persons. That 2 persons may not be there today. That gave rise to continue capacity building to be able to do routine maintenance and all of that. So key to our challenges are the resources and the capacity building that we have to do.
Thank you. Dr. Olaro, can you unmute yourself, or we'll unmute you? So I want to talk to you also. You've been having a number of different kinds of energy-related programs in Uganda. What have been some of the challenges that you've had in trying to get these off the ground? Maybe it's funding. Are there other types of challenges that you've been having? You're going to need to come close to the computer and speak, and turn off your video, sir.
Hello?
Very good. Can you talk now, sir?
Yes, thank you for this initiative.
So
definitely the challenges has been definitely that there's quite a very big demand for renewable energy. And if you look at the national grid for facilities which are linked to electricity are probably fall within less than 30%. And yet you find that partially those which are in the remote or hard to reach areas, the only available energy is definitely solar. But what has been definitely the biggest challenge has been issues of maintenance, that this is not, most times is not factored into any of the programs. So you end up by having systems which are not sustainable, and because definitely you have not built capacity for maintenance or replacement of batteries after they have served probably a period of 3 to 5 years. So I think that's now what we really, for any systems that we need to definitely be able to structure, that they be both community ownership, because they are the ones who will maintain it even for its own security purposes, virtually, because those which we find around the border areas, most of them have been stolen. Because find that either the panels have been stolen, and so you are left only with the part of the system. But we're definitely working with the partners. We've been able to improve access, and as I've indicated, this has been able to translate into increased utilization of the facilities. So there is satisfaction in terms of the users, including the health workers, because they will no longer be using either a phone, which makes their work very difficult, and this definitely also compromises infection prevention in most instances.
Thank you, sir.
So we're happy to work with WeCare Solar, and I think we're scaling these facilities, and the leadership both within the ministry and even the country are very supportive of that work.
Okay, thank you. Luke, we have for the practitioners, people are throwing down the gauntlet. Maintenance is an issue, guys. So how are you addressing it? Luke, I know that you worked on a lasting impact report that I think addressed the very issue of maintenance and sustainability. So what do you have to offer us?
So many things, Laura. Before I do that, I want to add one more barrier in the mix, which we're getting primarily from the energy sector, and that's the lack of data. The lack of data to help us make this much more of a priority. And that's talking about purely the data of where are these clinics, how much power do they currently have, how much power do they need? And secondly, what Huda already mentioned, the impact data, the showing how important it is, what is the multiplier effect, what is the impact of having reliable power on health outcomes. So I wanted to bring that in. Lasting impact, I luckily have a copy here at home with me, which I'm showing to all of you. It's downloadable on our website, and Laura also provided the link on the SCOL page for this event. In this report, we analyzed multiple multi-country, multi-intersectoral interventions that look at electrifying health facilities as well as schools. And trying to analyze what are the delivery models that are being used, why are they successful, but also looking at why are they not as successful as we want them to be? Why do we still find what unfortunately we need to call a graveyard of solar panels on the rooftops of these health facilities? Because we're not the first ones to talk about using solar PV for health facilities. The community has been doing this for the better part of 2 decades. What is new is this thinking, this collective thinking of moving beyond purely procurement, beyond trying to solve the problem now, and really trying to look at how can we make sure that what we install now keeps on giving, and that we can keep on reaping these benefits, not just for 5 years until the batteries die, but also for the next 5, for 10, for 15, for 20 years, as well as take into account how can we keep this going, how can we maintain the systems, how can we replace the key components. So what this report does, and I really encourage you to look at it, is distinguish between technical components of sustainability, organizational components of sustainability, and economic components of sustainability. And I'll just highlight one in each category. So on the technical one, maybe that's the most straightforward one. System design, make sure that your system is appropriate, make sure that you're actually addressing the real needs that are there at the clinic, which is where these energy and health needs assessments are absolutely critical. In organizational, I'd like to re-highlight the need for the right type of capacity and making sure that you have the right partners on board to implement the components that you need to implement. Thirdly, the economic sustainability, and that is really the toughest one to crack because we live in a world with limited resources. We know that public health is critically underfunded, and we're trying to set aside or here advocate for significant investments in what some see as infrastructures, what others see as a critical input in universal health coverage and reaching universal health coverage. So this economic sustainability and trying to find the right mix of funding, financing, incentives, so that we can overcome where will the money come from 5 years from now or 10 years from now to replace components. That is the part that we really want to focus on much more collectively as a sector between both the energy, the finance, and the health sectors, where ideally we move towards a more service-based model rather than the product model. So the product model is much more, you procure, you put it down, and then you kind of let things go, and you allocate some roles and responsibilities. In the service-based model, you put the service up front, and you, in essence, you don't care where the power comes from as long as it is there when the switch is flipped. It's hard to do in public health. It's hard to do in public primary health, which is why I feel everything we talked about before is absolutely necessary. The prioritization, the data, having the right type of funding, having the right type of capacity at all levels. But yeah, lasting impact, it's a wealth of information. So I encourage all of you to check it out.
Thank you for that great summary. Christina from We Care Solar, I heard a mention that one of the barriers is not having information. What have you been doing to address the paucity of research about the relationship of electricity and healthcare outcomes?
Thank you. I think it's a great question. So one of the things that We Care Solar does, apart from designing our solar suitcases and implementing them, is really around advocacy. I think when Laura started the organization of We Care Solar 10 years ago, this was really not much of a topic to talk about access to energy as part of healthcare. One of the things that we've done as an organization over the past 10 years is really consolidating and collecting information around, one, the issue with what happens when you work in the dark without access to electricity? What are some of the consequences of that? And then two, what is the impact of having access to light and electricity? We ourselves are publishing, hopefully this year, research around over 400 interviews we've done over the past 10 years around those issues. These are interviews with health workers themselves across 10 different countries in Africa and Asia. And we've also just recently completed a randomized clinical trial in collaboration with Harvard Public School of Health and Innovations for Poverty Action in Uganda, which is looking specifically at quantifying that impact. I think it's very clear that we all know that there are going to be problems that arise from the lack of access to energy and lack of access to lighting. But to be able to quantify the impact and the need is really going to help us to be able to advocate this issue more, demonstrate how important it is, and then hopefully get governments and donors behind this issue around renewable energy.
Thank you. So it's amazing that we've spent around 45 minutes not talking about the issue that probably everyone thinks about when we're not online, which is COVID-19. And that's an issue that certainly is very relevant to the nexus of energy and healthcare. And what I would like to know from the Ministry of Health officials, we have people on the phone from Zimbabwe, Liberia, from Uganda. Can you tell us how you're seeing COVID-19 affecting the urgency of the need to electrify health facilities? How is electricity an issue for you as you come up with your national responses to the COVID-19 pandemic? Bentoe. You'll have to unmute. There you go.
Thank you very much. Thank you. So this is an open secret, and Liberia is burdened, the already burdened health facility have now increased need for stable electricity, which, as I said earlier, we in Liberia have settled down on increasing the geographical landscape of solar system, because we know this is a reliable system. And I like what Luke said, reliable and adequate. So right now in Liberia, we know that all facilities may not be treatment facilities. There will be designated treatment facility. However, people will show up at the lower facilities. And these people who show up at the lower facility need to get tested before, when you are confirmed, you are sent to, you are lifted and taken to the treatment facility. And so this has increased the need for likely at all the facilities. Right now, it wouldn't be only facilities that are performing deliveries or antenatal care. It will be all health facilities in Liberia. So this is how grave the situation now is. And so with this, we know already if you are doing delivery, like I said before, Empower went off, it creates a huge tension and stress. How much more someone show up and you try to do tests, maybe because anytime the person show up, you should do the test. Now somebody show up and power is off. That would be very, very dangerous. And this COVID, we all know, is a very dangerous virus that we are dealing with. So right now, the need is greater.
Okay, thank you, Bentoe. I'm going to unmute you, Dr. Olaro. And I would like, sorry, I thought I just did. If you could unmute yourself. I'd like you to talk about sort of the role of electricity in the response in Uganda towards the COVID virus.
Come again?
We're talking about COVID-19 and how electricity plays into the equation for the COVID-19 response in Uganda.
Okay, first, definitely electricity, even without COVID, it definitely is one of the essentials which you need for a really effective service delivery. But now when it comes even now, much more essential that with COVID-19, definitely in terms of infection prevention and control, you will even need electricity much more, both at the points of the isolations, but also at the points of quarantine. And we are looking at that. This is what we will be able to provide. So you really need to that there's electricity available at those areas. But also you are looking at in terms of sterilization of your equipment and all other things which you need to be able to use apart from the reusables. I mean the disposables. You definitely will need what you will need. But care, because we don't want to lose focus, so that you find that you have more deaths from other causes other than COVID. So we really need to focus that there should be continuity of service. Mothers should still be able to access services, to be able to deliver in terms of emergency, comprehensive emergency, obstetric care, and or any other service which is needed. So electricity is essential with or without COVID.
Or you're muted.
Dr. Madzima, I know that you also have been really trying to prepare for COVID-19, and I would like to have you also respond to the same question.
So for Zimbabwe, we noted that the health system was already burdened before COVID-19, and this actually makes things worse. We have about 8 cases at the moment confirmed, but as a country, we have to be ready for the worst case scenario. So what has happened is we've come up in terms of the maternal health program, we've come up with guidelines which talk to COVID-19 and pregnancy. But we've also noted that there are programs which still have to go on, like the immunization program, which we've been doing very well. So we also have guidelines for in a situation where we have COVID. But having said that, like my colleague has said from Uganda, it has become even more important to have electricity now, for us really, we think having light is actually part of, it should be part of the protective equipment. So it's actually getting worse now that the health facilities which are going to be dealing with COVID-19, they should have adequate light for cases, for isolation, and for maybe treatment and also testing. So I think we should even take this opportunity to strengthen all the components of health systems delivery, including infrastructure, which for me, lighting falls under. Thank you.
Thank you very much. Kandeh Yumkella, can you unmute yourself? I can't tell which screen you're on right now.
I'm unmuted.
So we have the Honorable Kandeh Yumkella, Member of Parliament in Sierra Leone, and really a trailblazer in this whole area. He was the Chair of Sustainable Energy for All and the Director General of UNIDO, and has been really thinking about these issues. Oh, there you are. Wonderful to see you. Hi. Thanks for being here. So you've heard us talk about a subject very near and dear to your heart, right? And
Yes.
I'm wondering if you could maybe speak to some of the highlights, things that you've heard, and where you think the field is going and how people can be getting involved who would like to do something to really help to move the sector along.
Thank you very much, Laura. I've been listening a lot and learning quite a bit from the discussions you've been having. This is my third Zoom call from a very remote village in Sierra Leone. We just recorded our first COVID case today, and we're all in panic. But the bottom line is, I mean, you've all made the case why we need energy services to enhance healthcare delivery. No doubt, from diagnostics all the way to providing the actual services in hospital, you need access to reliable, affordable, and sustainable energy. I have been to Rwanda rural clinics. I have seen the difference between having electricity and what diagnosis you can do, and when you don't have electricity provided by solar or whatever means. I know that without the availability of electricity, we could not even store the vaccines in villages. And for us in Sierra Leone, with one of the highest, and in most years, the highest maternal mortality rate, we've seen women die just because we can't store blood in the hospitals. We can't do proper sanitation. And now with COVID, and it's good, Laura, you push the discussion also to COVID. I am in my village, very remote area with very bad socioeconomic statistics. Huda from India and SELCO have been here in my village. I'm going to the border checkpoint to talk to people about prevention. Well, you look at the PHUs there, the primary healthcare unit, they don't have electricity, they don't have solar panels. And some of the military guys are telling me, hey, Dr. Yumkella, can we have the thermometers, but bring something that will charge it for us so we can test these people who want to pass our borders. It's as basic as that. But yesterday I was in another location. We're telling people here to wash hands. Well, they don't have access to clean water. And yesterday we were inaugurating a location where we've put just 4 solar panels to supply water, and the boats are coming from remote islands to collect water to take back to about 5 to 6,000 people who rely on those 10 faucets just to collect water. They can do that because, yes, we have solar panels that can pump the water in tanks and put it in buckets and containers. They take back by boats. You should see the containers lined up, 5-gallon containers. So it's as basic as even having clean water available, but you can imagine the healthcare services. So indeed, you've made the case, but Laura, you set the tone. 72% of the healthcare facilities still in sub-Saharan Africa do not have access to reliable power. 25% of them have zero. So this is why we've come together to form what we call Health Energy Platform of Action, HEPA, H-E-P-A, that we've set up a secretariat now at WHO just to keep the message on. You, Laura, and all my colleagues from Uganda, Zimbabwe, India, Liberia who have spoken, we've made the case over 10 years. You have proven that, yes, with distributed energy, we can electrify these locations quickly. We can scale up when the demand increases. But the fact is, enough is not happening. Luke and others have made the case. They've done the presentations. I went to some of those presentations, but I think there was one even a year ago in Kenya. The studies are there showing if you have this quantum of energy available in a hospital, you can use these technologies for diagnosis. You can use these technologies for care, for providing care. So the case has been made, but we need the funding. So this is why we formed HEPA. It has several UN agencies. The secretariat will be at WHO, but we're going beyond that. It's also about politics. I now serve in parliament. I know that if you don't have the right leadership and if you don't have their minds in the right place, funding does not flow. The kind of planning you need. I mean, Luke was talking about some of the integrated planning you need, and Huda as well about the audits. It's not just about energy audits, it's about energy and service audits. It's also about skills audit. So if the planning is not done well, you have these facilities where an NGO may have dropped a solar panel, but it's not working. It's not been working for three years. It was good. Luke and others mentioned maintenance. I'm running with that problem now in my village. We put solar lights here 5 years ago. The batteries are dead now, so we have them dark. My village just got one of the first 52 mini grids. My country has the first 52 mini grids. We need probably 300-400 of those. But we had that mini grid working now in November. Of course, we're dealing with the issues of ability to pay, but the good news is our clinic will get it for free. In fact, the units are located right at the clinics. So I worry now about maintenance. The facility I went to yesterday to inaugurate is one where these water supply system, the panels were put in 5 years ago, but they stopped working after 2 years when they were installed. So the quality of what was put in matters too. The cable that was on the solar regulatory box that was put there matters. So this is why, Laura, what you're doing in terms of design matters. We have to design reliable systems you can install. We also, in design, have to think about the demand that will come once the electricity comes. So in short, you really covered the basis, but we need more action. We're hoping that HEPA will help raise money and put the agenda forward. We're setting together now a group of political leaders where we have ministers of health, ministers of energy in HEPA. We're calling it the coalition of leaders. We're going to back that with analytics from the UK and some other institutions like the World Bank. The UK has a huge program called MEX that is looking at energy and clean cooking, for example. But we're trying to do studies, additional studies with the World Bank and others, just to continue to present evidence. Politicians, leaders need the evidence to show the benefits, to show that costs are going down. And if you have the services available here, the numbers, how safe deliveries, the numbers go up. So we are hoping that HEPA, this health energy platform of action, will support all of what you've said here, but we're to build a bigger coalition, the same coalition, Laura, you and others were part of when we launched Sustainable Energy for All back in Brazil. And that's the first time I met you and you did those presentations. And of course, hearing the doctors talk about energy today, these are the people we need to put in front of heads of states, but also energy ministers, to make the case that here is how access to reliable, affordable energy enhances our healthcare delivery services. So we're with you, and I learn from you guys, and I run with the message to these various public forums. Over to you.
Thank you. And I know that you're also involved with the Rockefeller Foundation, that they have a whole panel as well, doing a coalition. And I think that, you know, from my perspective, it's a whole ecosystem of financial support. You know, we're going to need to have the World Banks and the Rockefeller Foundations working on this, but we have an immediate need and we can't wait years for these programs to happen. And that is why I think some of the people on this phone are actually funding some of the smaller programs. And we're going, you know, from foundation to foundation. Even high net worth individuals can make a difference right now. I think it's clear we're not going to have sustainable energy for all in all the health centers, by 2030, without a lot of people working together and all of us using the resources we can, both at the policy level and also practitioner level, Ministry of Health level, as you've said, we've been making the case for a very long time. And now we need to create whatever, the package to make those financial institutions that can take this on so that we can be lighting up continents and not just clinic by clinic. We've come to the end of our slotted time, though we started late. I'm happy to stay for a couple more minutes and let our panelists, if they want to, say any last words. I'm also going to recommend, there's some wonderful people who have actually been participating as attendees. And my suggestion is I'd like to write to all of you and give you opportunities to actually continue the conversation beyond this particular workshop. We used to have a practitioners group back in, I guess we started at about 2011 with Sustainable Energy for All and the UN Foundation. That's something we can absolutely activate again, because I think the time is right for us to be really accelerating both action on the ground and the financing for this very important sector. Luke, I'll turn to you. Would you like to say any last words, please?
Yeah, thank you so much, and this was really great, and good to see. I feel like we're all on the same page. We clearly have a big global pandemic, but at the same time, we also only have 10 more years in under the SDGs, and that's also super urgent. So we really need to move from making the case to get to action right now, and we need to do it in a sustainable way. As it relates to how can we keep the conversation going, thank you, Laura, for setting this up, for the Powering Healthcare Working Group that had been established. We're very keen to leverage that and to make sure that we bring in the voices of those who are experts in their field, whether it's on medical appliances, on solar PV, or on health system strengthening. We all have a role to play. So if you're interested to be part of that, reach out to Laura, reach out to me, and then we will definitely, you'll definitely hear from us. I'd say in the short term, primarily around critical appliances that are needed, especially in resource-constrained settings in many of the countries that we were featuring today, in helping them and supporting them to respond to this global pandemic. I'll keep it at that. Thank you, Laura. Oh, you were muted, Laura.
Okay, Bentoe, I've unmuted you. Final words from you, please.
Thank you very much. This was a very good opportunity, and I know, as I heard across the participants and also the speakers, I mean, the concern of clean energy or reliable energy is high. And one of the pieces that I wanted to touch on is the issue of maintenance. Like Lou said, production or procurement and installing, and that's not the end. So you are one of our concern also is the issue of maintenance. And right now we are working with the partners who have already started, like We Care Solar, UNDP, who are there doing the Beaker Hospital. So we are working with them on a 2 to 3 years maintenance plan, because we know with the solar circuits, after 5 years, we have to change the lithium battery, you have to change other things. And we also, for sustainability in the long term, we are working with the county health teams, because the health system is largely decentralized. So the counties, which are the lower level, have their own operational plans every year. So we are working with them to see how they can create a line in their operational plan to leverage some of the funding on the maintenance part of the solar system and solar circuits that are being provided. And we want to say thank you very much to We Care Solar. We are looking forward to implementing the maintenance plan so far. UNDP as well, who's doing our hospitals. And while we are working on these, we are also working with government to see how they increase the geographical coverage of the grid, the high grid, so that that can also help. But for now, the solar system is where Liberia wants to go. because of reliability, adequacy, and the rest of it. Thank you so much, and thanks to everybody.
Thank you. So thanks, Bentoe. I think that we definitely have been raising this issue several times about maintenance and sustainability. We didn't mention here one of our partner organizations, Green Lamp, based in Switzerland, has been working very closely in Ethiopia with a Solar Energy Foundation on a whole maintenance program. I'll be turning next to Christina to talk also about the way that we've been approaching that and any final words. But again, this is just the first conversation for many of us to be all in the room together. So let's not look at this as the end here, but that a starting point for many of us to continue these conversations. Christina, I'm unmuting you now.
Thank you. This has been a really interesting forum, and I appreciate you, Laura, putting this together. I guess I'll keep it brief, not to reiterate what other people have said, but when I think about what We Care Solar has where it's been over the past decade, it's remarkable what change a small NGO can do. And I think all the people that join the forum, all the panelists, there's a lot of skill and expertise and knowledge. And I would just encourage us to continue these conversations. Progress has been made over the past several decades, but as we all saw today, there's still a lot of work that needs to get done. But I believe that with all of the energy and excitement that we have and skills and expertise, we are able to make a big difference. So I just encourage us to continue to have these conversations and move conversations into actual action to make sure that we are really highlighting this issue.
Thank you. Okay, we'll try again for our wonderful colleague from Zimbabwe, Dr. Bernard Madzima. I've unmuted you. I'd like you to share some final words with the rest of us here.
Okay, thank you to We Care Solar for creating this platform where we also learned from colleagues countries and launching the campaign last month. We are looking forward to working with you in future, enlightening our youth facilities. Thank you.
Laura, you're on mute.
Thank you. Thank you, Dr. Madzima. I was just remembering how, it's always a reminder when we have colleagues that can't get adequate bandwidth that this is really reflective of some of the energy challenges that are in these very countries, and is sort of like reminding us that this is also happening in hospitals with equipment. Dr. Olaro, I think you are going to get the final word. I'm going to unmute you. Let's hope that we have good bandwidth. And I'd like to hear any last comments you'd like to share with the rest of this group.
Yes, thank you. I think this is what we definitely need to do. And I think issues of availing energy for the health care, because they go hand in hand, is really one of the key inputs which you have to be able to do, and is one of the quality indicators. And as you clearly indicated, we really need to work, all of us, both the governments and partners, and see how do we be able to avail energy even up to the most rural areas of our countries. I thank you all. I joined in late, but I don't know whether we'll probably be able to get a summary of all the issues which have come out so that we can be able to share them up and see how we can take some of those actions forward. Thank you very much.
Thank you. And Kandeh, just raise your hand if you have anything else to say. Otherwise, I'm going to close. Would you like to say something? I'll unmute you. Okay, Kandeh.
Just to say hello to everybody, and I know there are many people on the call. I got some text coming in, but I don't know the technology well, so I could not reply. But Laura, thanks for doing this. We all need to keep working, even though we are all at home, quarantined or on lockdown, but let's keep the flame burning, and let's look at the collaboration going forward. All the best to everybody.
Thank you. So everybody, I'll be sending out an email to those of you who have registered. I think that Luke and I will be in conversation about the best ways to continue the conversation going forward and create a platform where all of your voices can also be part of the conversation. We will be providing a summary of this here. There's also going to be a recording. So any of you who joined late, we will send out a link to the recording so you can hear it all, as well as notes that are going to be summarized for all of you. Thank you, everybody. Thank you, Wendy from SCOL, for allowing this to happen. I really hope all of you stay safe. I think that while we're all sequestered, as Kandeh mentioned, maybe this is a really great time for us to really put our heads together and have a very focused and action-oriented conversation going forward, so that when we are able to go out and back in the world and resume our activities, we can actually be bringing reliable electricity along with us to those health facilities we care so much about. Thank you all very much, and I'm going to sign off from here.
Thank you, everybody. Thank you for Liberia.